My pleasure. Thanks for having me. It's always great to be back in Tallahassee.
Great. Well, welcome everyone to Tally Talks. As you all know, Speaker Oliva started this a number of years ago to give us opportunities to bring in thought leaders on a variety of different topics to chat with us about their expertise. Today we have Avik Roy, who's with us, who's the president of the Foundation for Research on Equal Opportunity. It's a nonpartisan think tank that conducts original research about expanding opportunity, particularly for those who least can afford it. It's interesting. Avik and I were talking beforehand, and he's a MIT educated guy in molecular biology who then went to Yale Medical School. He goes to Wall Street, working for Bain Capital, J.P. Morgan Chase. Obamacare is coming down the pipeline. He's hearing all these arguments left and right, and he says, "Hey, I think everybody's missing the game here." And he tells me, I feel like I need to do something about it, so I don't know what to do. I start a website, avikroy.com, and I just start writing stuff. I just start telling people what I think about this policy and how I think it impacts America. And as a result of that, the Manhattan Institute calls and wants you to start writing, which leads, of course, to this career working on Mitt Romney's presidential and healthcare policy, as well as the Apothagy, which is Forbes magazine's blog on healthcare policy, entitlement reform, to this think tank. And this really has kind of, this has become your life as a result of really wanting to engage in one of the most important debates that we've had in the history of this country. So Avik, it's just great to have you.
Thank you. Thank you very much.
I've watched Avik give interviews a lot, so I'm going to wind him up and let him go here a little bit. I know we've talked about kind of the problems facing the country, what that looks like, your interesting perspective, as Obamacare was coming down the pipeline. So talk to us a little bit about that. Tell us the problem and some of your ideas.
Great. So I have some slides. Is my mic on, by the way? Yes. Okay, good. So I have some slides which are obviously up here, and it'll just be about 10 minutes. Just a bit of table setting, and then we can obviously talk about whatever you want to talk about, Chris, and whatever anybody else wants to talk about in the room. The theme I want to hit home for you today is what is it that Florida as a state can do to improve healthcare? As you all know, a lot of what happens in healthcare is dictated by federal law, federal statute, federal program. But there are some important opportunities for Florida as a state. And not only are there opportunities in the sense of making healthcare more affordable, but the opportunity is not just about being responsive to that problem of the affordability of healthcare. It's also about how Florida can bring in jobs from other states and other parts of the world. I used to work for Rick Perry. That's why I moved to Austin a few years ago to help Rick Perry's presidential campaign. And as many of you know, Rick Scott and Rick Perry were good buddies and used to travel around the country trying to recruit companies from each other states and other states and in California and other places to come to Texas or come to Florida. And one of the things I'm going to talk about today is how essential the cost of healthcare has become to the economic competitiveness of the state, particularly when it comes to the employer's perspective. So here's a chart that is showing the median household income in Florida over the last 10 years. And obviously, after the financial crisis, there was a little dip, and since then we've had the recovery, and incomes have grown. And that seems like good news, right? Well, if you subtract out the impact on the average household of rising health insurance premiums, the picture looks a little different. And if you then just kind of cut out that gray part of the chart, which is basically the effect on the average household of the median cost of health insurance for a family in Florida, you get this. And by the way, these are real. The blue bars here are nominal dollars, meaning it doesn't count the impact of inflation. If you actually include inflation, consumer inflation into this chart, the average household income in Florida, net of the rising cost of health insurance, has declined on an annual basis by 1%. That's how serious the problem of rising healthcare costs is. Floridians' living standards are actually eroding because more and more of their paychecks are being taken out to pay for the cost of healthcare every year. And this is not just a problem in Florida, obviously. This is a problem everywhere, but it's particularly a problem in Florida. So Floridians, of course, like to talk about how you're a Republican state at the policy level. You're doing a lot of good things to improve the market conditions. You have low state income taxes. So if you look at California in the U.S., this is what the rising cost of healthcare how it tracks in the U.S. and California. You know, it's as you know, it keeps going up. Here's what it is in Florida, right? So even though you have this free market environment here, low taxes, relatively low regulations, the rising cost of healthcare is a significant problem in Florida. And if you want to try to lure an employer from California to move to Florida because you think, hey, our taxes here are lower than they are in California. Yes, it's true. The taxes here are lower. The average, the per capita tax burden of state and local taxes in Florida is about $5,700. That's true. But look at what the average premium plus out-of-pocket costs are for health insurance. It's higher than what state and local taxes are for that median household. And so for those of you who rightly spend a lot of time thinking about how do I reduce taxes for Floridians, because you think of that as the biggest burden that you can impact as a legislator, as a policymaker, what I'm here to tell you is that what the healthcare industry is extracting from Floridian households is a far greater economic threat than what Floridians pay in taxes. And it's only getting worse. Every year that goes by, that yellow part of that chart gets worse. So that's healthcare as a whole, right? The cost of health insurance. How does it break down? If you look at national health expenditures, the biggest line items are hospitals, which is the yellow part of that pie chart. It's about a third. Doctors and prescription drugs. Those are the big three items. And if you actually look at private health insurance, it maps out a little bit differently. So physician costs are actually a big driver of the high cost of private insurance. Because if you think about it, everyone who's over 65 is on Medicare. People who are elderly use the hospital more. So that's why for them, hospital expenditures are the biggest line item. But if you think about people who are non-elderly, yes, hospital care is still a big chunk, but prescription drugs and physician costs are also very important. So today what I want to focus on for the rest of my time before we have our informal conversation is the hospital piece, because it is overall, nationally, the biggest line item, and it is one of the things that as a state, Florida and all of you can do a lot to affect. So here's something that I find really interesting and alarming, actually. I shouldn't just say it's interesting. What this chart is showing you is what Medicare and Medicaid pay for hospital care adjusted for inflation. So unlike the last set of charts I showed you, this chart is adjusted for inflation. What you see is that the growth in what Medicare and Medicaid pay for hospital care is basically tracked inflation. It's basically flat. Medicaid is a little bit lower, but they're both about the same in terms of the growth rate. Here's what private employers are paying for hospital care. 20 years ago, yes, there was a premium over Medicare and Medicaid, but it was modest. Now we're at a point where in Florida, the average employer is paying 2.3 times what Medicare is paying for hospital care. So you can understand why a lot of people are clamoring for Medicare for all, because they look at this chart or they have an impression or an intuition about that this chart is their reality, and they say, hey, I want that Medicare deal. I don't want to be paying what private employers are paying. And the point I'm trying to make here is that private employers, for a lot of different reasons, have failed or have proven to be incapable of negotiating on their own lower costs and lower prices for hospital care. And a big part of why is the problem of hospital consolidation, which I know that a lot of people in Florida have been concerned about. And so that's what I want to spend the rest of my time on here, is because this is a real opportunity for the state. There are a lot of things that you have to rely on Congress and Washington to deal with. This is one that really the state of Florida can and has tried to take on. And what I want to impress upon you is I know that the legislature is making some important progress on some of these issues of competition, but there is a lot to do, and what you've done and are doing is important. But relative to the scale of the problem, there's a lot more that we need to do than where we are today. So if you think about it more philosophically, how could you solve the problem of how regional hospital monopolies are taking advantage of their market power to charge higher prices? That yellow line in the chart in the last slide I showed you. Well, there's basically two ways to do it, if you think about it very simplistically. One would be to increase the power of the people who pay for health care, either through a government-run single-payer system, which can just dictate what we're willing to pay for hospital care, or you could have, I guess, a private insurance monopoly that could have that same dictatorial effect on what hospitals charge. The private insurance monopoly is problematic for other reasons, because then you have a private insurance monopoly, they can charge a high premium to you as a consumer, even if they have negotiating leverage with the hospitals. So that's not necessarily a great system. And single-payer healthcare has problems too, which I won't spend a lot of time on here, but I think many of you understand. On the other side, you could have a more competitive system in which instead of increasing the market power of the payers, you decrease the market power of the providers. So if you really want a market-based system, what you want is you want to have a lot of insurers competing with each other for your business as a patient, as an employer, and you want to have a lot of hospitals and doctors competing with each other to deliver those healthcare services to you at the best quality and the lowest price. So I'm going to focus on that second bucket because I'm a free market guy. So one category is stronger and more effective antitrust. The Federal Trade Commission, I was just at the meeting with the Federal Trade Commission yesterday, for various reasons that I can bore you with if you want later, has not been effective at blocking regional hospital monopolies from forming. And they have done basically zero to try to deal with the problem of hospital monopolies that already exist and are exploiting their market power to charge higher prices. The state of Florida has a lot of levers to try to attack that problem in terms of stronger and effective antitrust. Another thing Florida has been doing and can continue to strengthen is transparency into hospital prices. And what I mean by this is it's not just about what the consumer can see. Because if you think about it, most of us who have health insurance, 80 cents of every dollar we spend on healthcare is paid for by the insurance company. So what we need is transparency into what we're paying for insurance, and we also need insurers and employers to have visibility, particularly employers, into what a local hospital is charging to all the employers in that area, all the insurers in that area, so that employer can know, is my insurance company negotiating well for me or not? So transparency is not just about the consumer. Transparency also matters for employers and for the public, for public researchers to analyze hospital prices, for competing insurers. I love my friends at Florida Blue, but they love the fact that I'm sure, I haven't asked them, but I bet they love the fact that that there's no transparency into prices, or there's been less historically, because they don't want some startup coming into their turf saying, "Hey, I know what Florida Blue is paying all the local hospitals. We're gonna create an insurance product that's more efficient." They certainly would rather not have that competition. So this is a way of accelerating insurance competition as well. You can bar anti-competitive contracts. So this is something this is a really interesting element of what's going on in Congress right now. The Senate Health, Education, and Labor and Pensions Committee, or HELP Committee, has produced a bill called the Lower Healthcare Costs Act, which contains a lot of interesting provisions around anti-competitive contracting provisions. So what happens is a metropolitan hospital will buy a rural hospital. And then because that rural hospital is the only game in town, every insurer has to contract with that rural hospital, and then the metropolitan hospital, say a hospital in Jacksonville, will say, "Hey, if you want to contract with this rural hospital, then you must accept our inflated prices for our Jacksonville hospital." And that's the way that's one of the tools that hospitals are using to inflate prices. So there's a lot of stuff like that that's going on in these contracts. And then there are these gag clauses that say, well, the insurer can't disclose or complain about this contract in public. And so you guys don't get to have any visibility into what all these shenanigans that are going on. So what this bill would do is basically legally, it would be a violation of federal law to include those provisions in a contract, which creates a much tougher standard that could produce more competition. And the last thing is you could end monopoly price exploitation. You could simply say, and this is something that I've proposed, and is excellent in some bills that are circulating in Congress right now, at a very high threshold of market concentration, where you basically have a monopoly at a regional level in a particular county or metropolitan area, exempting rural areas because rural areas are obviously a little bit different in this regard. Let's just say that in that really concentrated market, you have two choices. You can accept Medicare Advantage rates from all payers, private insurers, public insurers, whoever, individuals, or you have to disaggregate that big hospital system into its local, smaller constituents and restore competition again. I call it auto-antitrust. It's a way of, instead of waiting for the FTC to come in and sue and have a 3-year court case and where you rely on a judge to hopefully break up this merger, basically you create an incentive for that hospital system itself to break up voluntarily into smaller units, because you're basically taking away their ability to merge purely for the purpose of raising prices. So those are some of the ideas that I have on this topic, and let me just stop there, and we can talk about whatever you want, Chris.
That's great. Let's kind of start a little bit where you finished. I mean, you talk a lot about this hospital consolidation, and I think the impact that it has on overall healthcare costs. I know you've done some work in comparing, the hospital consolidation in the U.S. and costs as compared to other industrialized nations in the world. And so tell us a little bit about, what those comparisons look like, and are we ahead of the game, behind?
Well, I think it's no secret to this crowd that we spend a lot more on healthcare than any other country in the world. And we also spend a lot in terms of government spending on healthcare than any other country in the world, which is remarkable. Think about how inefficient our system has to be, that we have tens of millions of people uninsured, and we actually subsidize healthcare more than any other country in the world. That's a pretty remarkable statistic. But in terms of hospital care specifically, what we're paying is about double what wealthy industrialized countries are paying elsewhere. And a big part of why is how other countries deal with this problem of monopolies. They're just more unsentimental about it, I guess. There's been this kind of passivity towards monopoly power. I think a lot of us who have a more free market or libertarian bent, we just sort of we've come to think of antitrust as this government intrusion into markets. But a monopoly is not a market. If you as a patient or as an employer have no choice but to engage with a particular hospital, that's not a market. And if we want to have markets, particularly those of us who want to not have a Medicare for all single-payer socialist system, if we want to have a competitive system, then we've got to restore competition. It's not the only factor. Purely competition alone will not solve all the problems we have in the healthcare system, but it's a big part of the problem that we have.
Let's talk a little bit about that. I mean, one of the things that the House in particular worked on for a number of years was, things like certificate of need reform, which I know you talked a lot about. And it really took, this House, this past term, or this past session, and leadership of Speaker Oliva, who made that a priority of his speakership, to finally get CON repeal passed here to start to do that. What have you seen as the impact of states who've moved in that direction? Obviously, we're in the beginning part of this, right?
Yeah.
So we've just done it. We're months after doing it. What are the things that we can expect, and how do you start to build on, bringing back some of those regulations and trying to open up the marketplace?
Yeah, I mean, if you look in general at states that either never implemented con laws or repealed them, say, 10, 15 years ago, you do see a lot more inpatient facilities. You see more facilities, and you see more competition as a result. And that does help a lot in terms of the problems that we've been talking about. On the flip side, it's hard to make generalities, because sometimes what's happened is, yes, you have a proliferation of hospitals, and then because of the wave of consolidation that's happened since then, not all those hospitals are necessarily still standalone facilities that are competing. So that's why repealing the con laws is definitely important, and I think because it's relatively new here, hopefully that helps provide alternatives. And I would say another thing about today versus, say, 15 years ago that's important is big data has changed the game in a lot of this stuff. Insurers have a lot, and employers, particularly now that you have an all-payer claims database, they have a lot more tools at their disposal to try to identify where low-cost providers are and send patients their way. I think an important thing that relates to all this is and I'm working on a project in Indiana where this has come up, and I think this is something that's interesting for you guys to follow as well, is one thing that hospitals will do is the form that they submit, the claims form that they submit to an insurer, to the government, to say, here's the service we did, pay us X. Sometimes on those forms, the actual site of service can be obfuscated, so that they'll claim this thing happened in a hospital, and you have to charge, you have to pay us a lot more than if it happened in an outpatient facility or a physician clinic. And through some of that kind of gaming of the system, even if you have, a hospital system that's got a lot of different places, and the con laws help, proliferate that, the hospitals are basically using that acquisition of outpatient facilities to charge higher prices. So it'll be interesting to see if the con law repeal and if there's construction of new hospitals, if that helps solve that problem. If you can get more accountability around the prices and highlight the opportunities for these new startup hospitals to deliver care in a more effective, data-driven way. I think there's more opportunity to do that because of technology than there was 10, 15 years ago.
want to talk about the data part as it relates to, cost and quality. A couple of years ago, we talked about how we created an all-payer claims database here as a way to build, on some of the ideas you talked about, which is, transparency and giving that to patients. That just went live before session. So the infrastructure's built. We've got over 80% of all claims data in the state that's available to the public to search. One of the challenges we see now is kind of the next step of that. Now that we have this infrastructure built, is how do we get Floridians to meaningfully engage with this opportunity, this portal, to look at pricing throughout the state in a really transparent way, when oftentimes the person who'd be searching isn't the payer, it's the insurance company's payer. How do we begin to think about that?
Yeah, that's a really important question, Chris, because I think too often, when we talk about price transparency, we talk about it in terms of, if the consumer has all this information, the consumer is going to shop. I can tell you, so last year, well, now in 2018, a year and a half ago, I tore my Achilles playing soccer. And I had to get an MRI to check it out and make sure I actually had completely tore it. And I'm like, I'm going to be this intelligent consumer. I'm going to go to all the websites, and I'm going to shop, and I'm going to look for the MRI and figure out where I can get the cheapest MRI. The amount of information I had to put on that web form in terms of my insurance and my health history and my all this kind of private information just to get a quote from a random MRI operator, and you spend 20 minutes putting out the form. After 3 of them, I'm like, I just spent an hour of my time, which I like to think is really valuable, trying to get a quote from 3 different providers for an MRI. And because I'm already through my deductible and have a 10% coinsurance, I'm basically going to save myself $20, right? And so I gave up and just went with what the guy that the doctor referred me to. And this is my point. Consumers certainly can benefit from a certain amount of transparency, particularly for the parts of healthcare that they're paying out of pocket for. But at the end of the day, for the average person with employer-based insurance, 80 cents of every dollar is paid for by insurance. And so what we really need if you really want to have transparency for the consumer, the best way to provide transparency for the consumer is transparency into what they're paying for health insurance. That's why it's so important, if you're a market-based person, to facilitate a market in which individuals are shopping for their own health insurance. This is one of the things about Obamacare that, in theory is good. It's good that Obamacare tries to encourage more people to buy health insurance. It hasn't worked out that way for reasons we don't have to rehash, but that concept is a good one, and we should be doing more of that. And this new Trump administration rule, called the HRA rule, would allow employers to say, instead of buying health insurance for their workers, we're going to give you a health reimbursement arrangement. Let's call it $7,000 or $10,000 or $12,000, depending on if it's individual or family policy. Go shop for coverage. Take that $10,000, shop for coverage, and if you find a plan that's $8,000, keep the change. That's price transparency on the most important part of that healthcare dollar, which is the 80 cents that insurance pays for. And on the flip side, with an all-payer claims database, what does that do? That allows these employers and insurers, and particularly competing insurers, to see what we can do to lower the cost of healthcare. So what I'd love to see Florida do is, some of you hop on a plane, go to Silicon Valley and say, hey, venture capitalists, if you've got an idea for a startup insurer, park it in Florida. We have an all-payer claims database now. Use your AI, ML, big data chops and figure out how to slice and dice that data so you can produce a better product than Florida Blue or Aetna or United or Cigna or whoever. And that's the way you're going to get more competition.
So along those same lines, right, there's this notion out there that, we often see hospitals kind of blame insurance companies. We see insurance companies blame hospitals for the crisis in healthcare. But there's this idea out there that, look, they're kind of cooperating with each other a lot of the time, with the idea that, while it seems counterintuitive that health insurance would want to pay more, the reality is the higher the price, the higher their margin, the higher the dollar amount potentially that insurance, might garner for themselves and their corporations. I mean, do you see that kind of alliance of raising the cost throughout the U.S. and how do you balance that with kind of what you just said, which is bring these innovative healthcare companies in who aren't going to play that game?
Well, this is why I'm glad I don't have your job, because I'm not accountable to the voters, right, or to the stakeholders. I just going to pontificate from my keyboard and let the bombs fall where they may. The Uwe Reinhardt, famous Princeton health economist, he used to say that, of the $3 trillion a year we as a country spend on healthcare, that $3 trillion if 1/3 of that is waste, that $1 trillion of waste is someone else's profit. right, or someone else's income. And that's the problem, is like everyone loves to complain about the high cost of health care, but if you're an anesthesiologist, it's not my fault. I have to charge 9 times Medicare. Otherwise, I can't pay my bills. It's the drug companies. Blame them. Or it's the hospitals. Blame them. And the hospitals say, oh, yeah, we have to charge what we charge. It's the pharmacy, where we're spending all the money. Or it's the neurosurgeon that we have to pay $1 million. So, it's always somebody else's fault, right? Everyone agrees that healthcare is too expensive, but it's everyone else's part of healthcare that's too expensive, not my part. And that is what makes your job tough. And the way I try to think about that, and the way I try to advise policymakers about this challenge, is go after the least defensible practices. If you do the sort of Medicare for all type approach, there are a lot of things wrong with it, but one of the biggest things wrong with it is it will never happen, because you will never convince the entire healthcare industry to whack their prices by 50%. It just will never happen. Look at the surprise billing, stuff that's going on in Washington right now. They basically can't get it done, and surprise billing is a relatively small problem because the people who would be affected by the surprise billing legislation don't want to see their prices go down. So I think part of it is you attack the least defensible practices in terms of the real monopoly exploitation that I highlight in the slides. And also some of the things you're already doing in terms of transparency. I think transparency is one way to create more tools for the public, for researchers, and for Silicon Valley entrepreneurs to identify opportunities to reduce costs.
How have you seen in this this consolidation of hospitals, how have you seen the purchasing of physician practices? We hear from a lot of our constituents and people from throughout the state, hey, I'm trying to get a primary care doctor, and the only primary care doctor I can find is a practice that's wholly owned by a hospital. And in fairness to the docs, I think some of the docs are saying, hey, we just can't afford to be in this market anymore with all the regulation. It's just too much. It's easier to sell to a hospital, which will essentially take over all of that bureaucracy. And so how is the consolidation of physician practices playing a role in the overall rise in healthcare costs?
It's a big problem, and there's a lot of things to say about this. One of the big drivers, there's 2 big drivers of this, or maybe 3 big drivers of this problem. The first is that Medicare pays more for exactly the same service if it's administered in a hospital setting versus an outpatient clinic, which is just mind-bogglingly stupid, but that's just because that's the way Medicare was designed in 1965, and we haven't managed to change it because the people who benefit from that arbitrage want it to stick around. But Florida could do something about that, and that goes to some of the things I was talking about before, about if you really specify the site of service where care happened at an exact facility and an exact department or ward within a facility, you can start to attack some of that. Another element of it is you've gotten to a point now where most regional markets are so consolidated in terms of the hospital systems that's the last kind of brick in the building of monopoly power, is to vacuum up all the physician practices so you can control the referral volume to your hospital and steer those patients to your hospital as opposed to another hospital. The third piece is something that comes out of the Affordable Care Act, which is accountable care organizations, right? This idea that, if we actually merge hospitals and outpatient facilities, then patients will get more integrated care. Well, you know that hospitals love that because it was basically a way of saying, hey, I'm doing the right thing by patients by acquiring all these physician practices. See, I care about patients. This is going to be great. We're going to integrate care. Well, now all the academic research comes out saying that we don't save any money because of monopoly power problem, and patient care is no better. And in some cases, it's worse because you've created these giant bureaucracies that have diseconomies of scale when it comes to patient care. So it's been a huge problem, and I'm glad that more people are becoming aware of it. Another thing about it we talked about before we walked on stage is that from a Federal Trade Commission standpoint, these acquisitions aren't on their radar because if 2 big hospital systems merge, that's the kind of thing that the FTC actually really triggers their activity at the FTC. But if a big hospital system buys a tiny little physician practice, that doesn't meet the threshold of consolidation activity that they then get concerned about. So this is again an opportunity at the state level to start maybe doing more on it. I'll tell you what, a lot of the physicians are concerned about this, so this is an area where you can create some stakeholder on stakeholder violence, and that's always good in healthcare reform, right?
We try to encourage that here in the
Yeah.
house, actually. So, you talked about, hospital consolidation. You talked about, buying up, physician groups. You talked about, before we did CON, the ability of hospitals to kind of control a regional area. How are you seeing, we're starting to hear now, hey, in addition to doing all that, right, so I've gobbled up the physician groups, I've done consolidation. Now it sounds like a great idea for me to also become an insurance company.
Right.
So have you seen that play out, and what is what are the potential problems of that continued progress into consolidation, and now I'm an insurance provider?
Yeah, it's interesting because in some parts of the country, this has been a big problem. The example that comes to mind is the University of Pittsburgh Medical Center, which has started an insurance company that has basically, because of its favoritist status within the UPMC system, has gained a lot of market share. In general, hospitals have not been successful at running insurance companies. It's like anything in life. Like if you're a business and you try to start another business that's very competitive, you may not be that good at it, right? And so you may think you're good at it, and you may think you have a certain advantages to that integration between the hospital and the insurance company because you can give yourself a better deal than others. But in a state that's as diverse and competitive as Florida, I'm more sanguine that that strategy won't work because there's so many insurers who are in the insurance business have been in this market for so long that it's just hard as a hospital to just create a product that's competitive, particularly from a price standpoint. I think in markets where there's more of one regional hospital monopoly that really has more statewide control, that can be more of a problem than I hope it would be in a place like Florida. What you're also seeing, by the way, and I think this is more of a positive trend in a sense, is you're starting to see insurers build and buy primary care and outpatient facilities. And I'm more actually, in maybe a counterintuitive way, I'm somewhat open to and optimistic to that. And the reason why is because it counteracts what you were talking about before. If the hospitals are buying up all the physician practice and steering the volume, a lot of insurers are responding by saying, well, you know what? I'm going to create the primary care facility and then steer the patient to the most cost-effective provider from my, as an insurer standpoint, from my point of view. And that can be a counterweight, at least, to that problem.
Sure. That's you talk a lot about in your articles about using technology innovation both in the tech space, medical tech space, as well as policy innovations. The House has passed things like direct primary care to allow for a subscription-based model. Yeah. Last year, the House made it a priority, and the Speaker did to pass telehealth, which we've been working on for a number of years. What are the innovations in policy and tech that you see that can help do some of the things that we're talking about in lowering costs and opening up access to everyone?
Well, the most important, from a thematic standpoint, the most important thing I would say is the more you put the money in the hands of the consumer, the more innovation can happen. Like the more you move to a system where insurance is like car insurance, where you total your car gets stolen, it pays for that. But we think about, when you think about your car, when you get an oil change or you fill your gas, that's not paid for by insurance, right? If you had health insurance that worked along the same model, then there'd be more room for innovation in those areas. So direct primary care is a great example. Actually, Florida is really the epicenter of the direct primary care revolution, as many of you know. And that's an example of where you take money that the consumer is paying out of pocket to say, hey, instead of just, I'm going to pay you, the doctor, for your time rather than for your prescription pad, that makes a huge difference. And there are a lot of people, in terms of both in Silicon Valley and in Florida, who are trying to innovate on this model and say, hey, let's do more to not only in terms of direct primary care, having that hour with the doctor instead of 5 minutes in a kind of assembly line, but also think about this. This is another thing where, again, a lot of innovation is happening is think of how much more we can do in the home setting. And telehealth plays a role in this. Like if you got, your Apple Watch or your Fitbit or whatever it is, and you've got other things in your home that are monitoring your health status, and then transmitting that to your primary care physician and others who are caring for you, that can do a lot to allow a lot more care to take place outside of a healthcare facility, whether it's an inpatient or outpatient facility. So the more integration you can have of that kind of data, of your blood pressure, your heart rate, your health status, into that broader system, the better. So I think there's a lot. Telehealth is not just about rural areas that have challenges with access. It can also be important in urban areas where a lot of the stuff that takes place in the home can be more relevant to your health care and prevent you from having to go to the hospital.
Let's let's switch gears a little bit to how you kind of came into all of this, which is this debate about Obamacare coming down the pipe, and you hearing kind of people who I think you've called traditional conservatives, people on the left who were talking about health care, and you figured that you thought that there was this huge missing piece that people weren't talking about, and you've come up with a plan that has 4 core principles to deal with that. So talk to us about what that is and what are those core principles.
Well, I would say that the reason why we started this new think tank, the Foundation for Research on Equal Opportunity, just to broaden it out even more, is that the healthcare debate has taught me that there are a lot of things, a lot of areas of public policy that make a real difference for people, where what we think of as this irreconcilable partisan divide between Democrats and Republicans isn't as strong or as real as we think it is. All of us want every American, every Floridian to have affordable health insurance. All of us want every American, every Floridian to have an equal shot at success. At least I'd like to think we all do, right? We may have different ideas of how to get there, but if you actually look at polls, 80% of Americans believe in that principle of equal opportunity. And so when you see on cable news, oh, well, we just have this fundamental difference of values and we'll never agree on anything. Actually, that's not what I see. I see a country in which 80% of Americans all agree that every American should have a fair shot at success regardless of where you came from or what your family background is. We might define equal opportunity a little differently. We might define how to get there differently. But that's actually an opportunity for unity. And so at our think tank, what we try to do is find those ideas that can get 60 votes in the U.S. Senate and get through a filibuster. And how do we do that? We do that through looking at market-based reforms that can make life better for Americans whose incomes or wealth are below the U.S. median. And by that way, we can attract people who think of themselves as progressives, who care about social mobility, and people who are conservatives who care about markets. Because at the end of the day, there are a lot of people who don't mind if it's a market-based solution if it expands social mobility. And there are a lot of people who obviously don't mind if it improves social mobility if it's a market-based idea. And so in healthcare, that's especially true. That if you look around the world, there are a lot of countries that have achieved universal coverage through private insurance and through individual choice. It isn't all single-payer countries out there in Europe and the rest of the industrialized world. And so I've tried to learn from that in the work that we've done in healthcare and in other areas. And so what are the core principles of our health reform proposal at FreeOp? The first is that we want it to be affordable for every generation. And what do I mean by that? Not just affordable for the people who are living today. It's important that not just every American living today have affordable health insurance, but that our children and grandchildren and their children and grandchildren have affordable health insurance. If we've made health insurance available and accessible to everybody in America today, but we've made the system unsustainable for future generations, we have failed. We haven't succeeded. So it's really important to do both, to have a system that's affordable for everyone today, but also affordable for the future. Second thing is we need to have a system in which there are multiple personalized options. So right now, most Americans have basically a single option, whether it's your Medicaid program or it's your employer-based health insurance that your employer has picked for you, right? And so one thing Democrats talk about is they say, well, let's have a public option as an alternative to that. And that you could say, hey, 2 options is better than 1, right? But why should we only have 2 options? Why shouldn't we have dozens of options? Every American should be able to choose between dozens of options for health insurance that are affordable, and that competition will lead to better and more affordable products over time. So having personalized options and many, many personalized options is really important. The other principle I would really highlight is the principle of monopoly power. That if you really want to have a system in which there is true innovation and true choice and true affordability, we've got to tackle the problem of monopoly power. That's particularly bad with hospitals and drugs, but it's also an increasing problem with specialist physicians. In Austin, when I got my Achilles fixed, the anesthesiologist charged more than the surgeon. And why? Because there's all the anesthesiologists in Austin have come together in one group, and they negotiate with the insurers in the hospital and say, hey, you want an anesthesiologist? You got to basically take our price. And they succeed with that strategy, right? So that's an important part of high health costs too. And I think those of us who are on the market-based side, we've got to really be aware of that problem and not just accept monopolies as a free market system. They are not a free market system, and we have to be vigorous about antitrust and pro-competition if we want there to be a market-based solution to healthcare in the future. And the last principle, which I sort of skipped over, but I'll mention is important as well, is we really have to reserve financial assistance or focus our financial assistance at the government level, at the public level, for the people who really need it. One of the biggest problems with the American healthcare system, the reason why subsidies per capita in America are higher than every other country in the world, is because we massively subsidize the cost of healthcare for rich people. All of us in this room are paying taxes so that Warren Buffett and Mitt Romney can have government-subsidized health insurance through Medicare. High-priced lawyers and investment bankers get government-subsidized health care through the tax code. This is insane. We have an incredibly regressive system in which the working poor can't afford health insurance, and a big part of why is because of what we do to subsidize health insurance and health care for the rich. And so if we as conservatives, or at least you and I as conservatives, want to have a system in which we spend less money in terms of subsidies on health care, don't do it by cutting subsidies on the poor. Do it by cutting subsidies on the rich. And I think you can get a lot of bipartisan support for that. At least I hope you can.
One of the, I'll ask, this question, then we'll turn it over to any questions the audience has. So if you're thinking about some questions, we had a debate over several sessions about Medicaid expansion, and the majority of House members rejected Medicaid expansion, thinking that it wasn't the right thing to serve the poor, which I know you've written about. Recently, we're hearing out of the administration that there's some openness of something that we've been talking about for a number of years, which is a Medicaid block grant. It's long been kind of our position that we could maybe do some more innovative things. What is your thought on that prospect?
Yeah.
And let's assume you could wave a magic wand. Would you want that to happen? And if it did happen, what would you suggest we do with it?
So a lot to talk about in that context. First, so if anyone's interested in my take on Medicaid, I wrote a very short book which you can read in half a day or even less, called "How Medicaid Fails the Poor," which expresses, just first of all, describes why Medicaid's health outcomes are no better than those for people who have no insurance, which is shocking, but is really true and is backed up in the literature. And there's a lot of reasons for that, which I go to in the book, that have to do with the way Medicaid is designed. And this is, again, not to say that we don't want everyone to have health insurance. It's just that Medicaid as a program is particularly dysfunctionally designed in delivering that outcome. So the thing I've talked about a lot is let's actually use private insurance, and not just Medicaid managed care, but actual private insurance that people individually choose to support the purchase of health care for Floridians and other Americans. So for example, right now, if you are between 100 and 138% of the federal poverty level today, you're able to get pretty heavily subsidized coverage through the Obamacare exchanges. If you expand Medicaid in Florida, that's taken away from them and replaced with Medicaid, which is a much worse form of coverage. So what I'd like to see is to give states the option to actually drop eligibility for the exchanges below 100% of the federal poverty level to fill in that gap in a way that is more integrated. Think about it right now. What happens not just in Florida, but in any state. Let's say you'd expanded Medicaid. People who are poor, their incomes go up and down month to month. So one month they're on Medicaid, the next month they're on the exchanges, the next month they might have employer-based insurance, the next month they may have nothing. You're having to re-enroll and disenroll from different insurance programs with different primary care physicians. It's hard enough being poor without having to deal with that problem every day, right? We should have a more integrated system in which, yes, the amount of financial assistance you get goes up and down, but you're able to keep your plan and keep your physician network intact. That's a really important thing, to have that continuity of coverage, which expanding Medicaid would disrupt, in my view, in ways that you could do something better to solve. Remind me, so you had some other questions in there about the block grant thing. So what the Trump administration just proposed is having a bit more flexibility around the Medicaid expansion population. So unfortunately, the block grant proposal the administration is putting out there would not affect the legacy Medicaid program that's active in Florida today, so it wouldn't be relevant to that. And yes, you're right that in general, having more flexibility for states would be a good thing, but I would even push farther than that. At the end of the day, what I want to see, ideally, in my world, is not merely block grants to states, but block grants to individuals. Because at the end of the day, central planning at the state level is not that much better than central planning at the federal level, yes, maybe if you have 50 states and you have the laboratories of democracy, maybe you get a better result. But those local providers are pretty powerful factors in your line of work too. So I look at it like if you want to drive cost effectiveness and have a better system, put those dollars in the individual's hands and let the individual choose the health care and health coverage that he or she needs, and then you're going to get the best possible system.
That's great. That's awesome. All right, questions. Chairman and also Dr. Pigman.
Yeah. Hello.
Thank you for your presentation. Is there a way to square or get through the eye of the needle to resolve the monopoly price exploitation when you're considering large vertically integrated providers like the historical Kaiser or Geisinger Clinic through capitation or making the provider, the facility provider, risk-bearing?
Yes, but so some background. So if you look at Kaiser, as we all know, Kaiser's origins and kind of bases in Southern California. If you look at the Obamacare exchanges in Southern California, Kaiser has the most expensive product because their network is so kind of baked in. They can't do what a typical insurer does and say, okay, we're going to go to the low-cost provider here and the low-cost provider there and the low-cost provider there. Their network is already fixed. And they can't just say to all their physicians and hospitals, sorry, we're paying you less. So interestingly enough, though obviously we all think of Kaiser as a high-quality provider of care, from a price standpoint, it's not actually that, it hasn't shown itself to be that competitive. And so the second part of your question was, can that model, remind me?
Through capitation or risk-based.
So yeah, so that basically, yes, if they're willing to accept lower unit prices for a lot of the services that they offer, and we haven't seen that. And so I actually look at it like, again, if you look at technology, what technology allows us to do is coordinate care without having all the providers in one corporate unit. Right? So what was the theory behind ACOs? That if you have the hospital owning the outpatient clinic and all integrated like a Kaiser or Geisinger, that's going to create integrated care. Why do all these units have to be within one corporate institution to coordinate care? Can't I coordinate care between the two of you without that? With email and cell phone? So all that to say that the big obstacle there is outdated privacy regulations that basically make it impossible for patient data to be transmitted from the primary care physician to the endocrinologist to the hospital. And so there's a lot we need to do, and we talk about this in our health reform plan at FREOP, to reform and modernize privacy regulations like HIPAA so that patient data can get to the right people, of course with the patient's consent, so that care can be coordinated without having it all to be integrated into a single corporate entity. And that's also, by the way, relevant with anti-kickback laws, which make it very hard for independent providers to talk to each other in a way that's economically useful.
Other questions? Representative Overdorf.
Thank you. So we in the area where I am, we had a large conglomerate come in from Cleveland and took over an area. And they then also have an insurance company that is the only insurance company they take. So it's not necessarily that they have started their own insurance company per se, but there's only one brand of blue that they actually take. So that is their monopoly, if you will, in that side. There have been some others that have come in, but the cost of utilizing those insurance is way high. So what are your thoughts then on promoting competition, if you will, for the other insurance companies to come in, and or how we can maybe promote some additional opportunities for other insurance companies to come in?
Really interesting question. Without knowing the real detail, I have to really dig into the details to give you an informed and definitive answer, at least as to what my take would be. But in general, this is a clear case of where antitrust or scrutiny of monopoly power is relevant, right? If you've got a single hospital system or provider that basically owns a particular county or set of counties, and they're only taking one insurer and not taking the others, presumably because those others want a lower price, that's a classic example of monopoly power. And so it seems to me that the state should already have the statutory authority to go after that and scrutinize that. And if that's not the case, then there's a role for the legislature to do something about that.
You have time for one more question, Chair Burton.
Thank you. Quick question, I hope. We have a piece of antitrust legislation that's now in its second session here in the House, with not necessarily moving as easily on the other side of the rotunda, so to speak, but some of the pushback that we've seen, significant pushback, is coming from management organizations that hire specialists, and place them all across our state. And quite frankly, many of them are multi-state organizations. How big of a problem is that? Not just in Florida, but nationally.
Yeah, so I'm not sure if you were here when I was talking about with my Achilles, where the anesthesiologist kind of took over the city of Austin and have done that, and that's a big problem. And I think it's also important for the broader problem of the cost of hospital care, because if you dig into why hospitals are charging what they're charging, there's a lot of upward pressure from the physician staff and the surgical staff that's leading, and that they're basically saying, well, the neurosurgeon wants more money, and I can charge whatever I want, so I'm going to charge more. They just pass it along. And so there is room for scrutiny of that. Obviously, the biggest, the specialist physician problem is I think the hardest problem. I mean, they're all hard problems, right? It's hard to take on drug companies because they got lots of money. It's hard to take on hospitals because they're the largest employer. But the physicians, boy, you mess with the physicians and they kind of marching around, right? Like, so I kind of left that to the last frontier, so to speak, in my own work, because it is such a big and challenging problem. But it is an important problem. I think the first step is really, and we have some reporters in the room, I think our friends in the press need to do a lot more to highlight. We do a lot to highlight the exploitative practices of drug companies and hospitals. We've done it for a long time with drugs. We're increasingly doing it with hospitals, but we really haven't done it a lot with specialist physicians in particular. So I think the more the press and researchers start to focus on that problem and make the public more aware of it, maybe that gives you all more political capital to do something about it.
Awesome. Well, Avik, thanks so much for being with us. We
All
so
right.
appreciate you.
Great
Thanks
conversation.
A lot.
Thanks a lot.
Absolutely.
Best of luck to you.
We have a 12 o'clock meeting.